Okay, welcome everyone and welcome to our session on improving induction. I am Tisha Chakraborty-Gannon. I co-lead the outreach team at GMC and I am delighted to have with me today Prof Marla Rao, a leading light in supporting international doctors, and Dr Rachel Rummery, a leading light in supporting returners to the service. So, all things being equal, I am going to share my screen now so that the slides load up. Let's have a look. Okay. Now, I seem to be having a slight technical problem, so I'm going to have to ask our technical host to load the slides for me. They're just, having tested it last night, they just don't seem to be appearing at the moment. Thank you. Okay, marvellous. Okay, I can see more people are joining, so I'll just give a few more moments and then we will get started properly. Okay. I think we are there or thereabouts. So if we can move on to the next slide, please. Marvellous, thank you. So what Marla, Rachel and I would like to do today is really explore with you how we can support doctors returning to UK practice and those joining new to UK practice. What we aim to do is to take you through our experiences, the challenges that we're aware of. For the first half hour or so, each of us will share some background around that, and then we'll move to breakout room discussion. Now, the breakout room discussion is where we're really interested to capture your insights and your ideas around how we improve induction. There will be GMC facilitators in each room, because from our point of view, we don't want this to be a workshop and then it's done. We want to take forward your ideas and undertake follow-up work, inform the work that we are doing. So that's going to be really important. Now, the session as well has had quite a number of people sign up to it. By popular demand, we've also extended the wrap-up, allow for a bit of panel Q&A as well as the usual Q&A at the end. So that will take us to 1 o'clock to the exhibition for those that wish to stay for that. So that is the plan for our workshop. If I could have the next slide, please. So first, by way of brief background, to share a little bit about my journey with all of this. So I've been in and around healthcare for about 25 years now. I work still with survivors of abuse, and about 10 years ago, I joined the GMC. And a colleague and I were asked to set up a support service for doctors on the ground. And I remember thinking at the time that that was a really progressive thing for a regulator to do. And I was really excited. I like being at the vanguard of things. And there'd not been anything like that around, certainly when I started working within the services. And yes, I was invigorated. And then as I started to make connections across the country with various groups of doctors, various organisations, during one of my first ever conferences, if I could just have the next slide, please. I remember I was walking on to the conference podium and I was introduced, if I could have the next click on the slide, to the theme of the Imperial March. And that's Darth Vader's theme tune, for those that don't know. And that moment crystallized for me just what fear we can be beheld in at the GMC. Yes, the hosts, the conference organisers, a group of GPs were joking, I think, But nonetheless, it was a very, very serious moment for me in understanding what perceptions can be. And I understand why we are thought of predominantly in fitness practice terms. But as I started to learn more about what we do and what all our functions are, I came to realize that actually, next slide, please. As this image that will come up on the next click, please. As this image shows you, these are our statutory functions, standards there at the centre. That is the absolute fulcrum of what we do. It informs absolutely everything. And the serious fitness to practice issues that we see, the really, really serious issues that we see, apply to such a tiny minority that actually the more that we can do at the GMC, but more widely as a system, to support colleagues on the ground to deliver what are, let's face it, challenging standards in what is, let's face it, an increasingly challenging environment, well, that's better for everyone. So on that theme, if I could just have the next slide, please. Oh, thank you. If I could go back to the previous slide, sorry. Thank you. On that theme of challenges, it has been several years now that colleagues on the ground, what I see in domestic violence services, unfortunately, particularly now under pandemic conditions, workload has felt like an increasingly Sisyphean task. And if you would indulge me for a moment on a slightly tangential take on that, if I could have the next slide. I'm going to give you 10 seconds to have a look at the slide that we'll reveal on the next click in a moment. You'll have 10 seconds to find the mistake on the slide. Now, for expediency, if we were in a live room with you, then I would ask you to shout out once you find the mistake. But just have a think and see if you can find it. So, Oliver, if you can click to the next animation. All right, 5, 4, 3, 2, 1. I wonder how many of you saw that. It's, can you find sorry, can you go to the previous? Can you find the mistake? There are 2 the's there. And, you know, that slide, that image, it's designed to hoodwink you, isn't it? It's got the different font sizes, the different colours and all of that. And the point of that is that actually it can be really, really easy to miss small things. And in a live room, we will often see that, well, about 25% of colleagues will find that mistake. And it's quite good fun if you do want to use a similar exercise yourselves. It's quite good fun to pick colleagues in competition with each other. But as I say, the serious point is that you can miss small things in a pressurized environment. And that is somewhat analogous to the system, the service. Working in the service in a pressurized environment, we can miss things. And moving on to the next slide, I would say that when we are doing and doing and doing without that space to think, then a number of things happen. We miss those small things. That can harm patients. That can harm us. And on the next click, what I often say is that, well, it can lead to burnout. That constant doing, as per the dodo. So can we move to the next slide, please? So bringing it back to what we need to do in the system and sharing this image from the people plan. We have a responsibility to support our people. The environment that we have now, the workforce challenges that we have now, it behooves us to support our people. And that brings me on to induction. If I can have the next slide, please. I'm going to share some quotes with you now from international colleagues that I've worked with, and they're happy, of course, for me to share these quotes. And these are just some examples of their experiences. So if you can have the next click, please. And I'll pause and just let you digest those for a moment. And those are, well, they range from poignant to just downright sad, downright depressing. That penultimate bullet there about a colleague who got the catheter from the cupboard. The story behind that. This doctor, in his country of qualification, catheter. In the UK, we have two types of catheter, male and female, at least. And he joined practice here, and a few weeks in, he was asked to get the catheter from the cupboard. He was working on a male ward. The cupboard had female and male catheters. He picked the female catheter. And it's things like that, but more broadly as well. If we can move on to the next slide, please. I'm now going to share a series of bullets with you. And I want you to have a think, just as each point is coming up. What does this list represent? So if you can click through each bullet, please. Okay. And have a think. Have you got it yet? Have you got an idea of what this list represents? I think most of you will have it by now, those who work in the service. Yeah. It's induction. This is actually my friend from Sudan. When she came here to practice, that was her induction. Where's the culture shock? Where's the stuff about, well, this is how the NHS works actually. Where's pastoral support, mentorship? Where's the support in general? It is incumbent on us to provide that. And if I can have the next slide, please. And we were talking earlier at conference about our State of Medical Education and Practice report, and our inaugural report in that there was no standard induction for colleagues in the system. So we created one at the GMC, and some of you, I certainly hope, will have heard of Welcome to UK Practice, and it's a GMC induction that is half day. So it does not cover absolutely everything, and nor should it, because our focus is clearly on our standards and guidance. And if we can move to the next slide. Despite it not covering everything, what it does cover works. And if we can have the next click, please. And again, I'll just let you digest that for a moment. This is the evaluation top that just shows you this is what colleagues attending the course say. And we've also had academically robust evaluation to demonstrate that actually, even at follow-up, colleagues' practice has changed. So this is the difference even half a day's workshop can make. So, as I say, it is absolutely incumbent on us to support our colleagues when we can see what a difference just a half-day workshop makes. When we are aware of all the challenges in the system, we need to do more. And can I have the next click, please? Yeah, we need to do much more. And especially as the pandemic pressures are on us, returners and support for returners is becoming more and more important. And with that, I'd like to hand over to Rachel, my colleague, who is going to tell us a little bit more about that. Thank you.
Hi. Can you hear me? Good afternoon. Thank you very much for inviting me to speak today. I'm really thrilled to be able to speak about the developments in return to practice. I am Rachel Rummery and I'm clinical lead in return to practice in health education England. Could I have the next slide, please? Next slide. Wait, my nose a little bit. So I'm going to talk about return to practice, which is a really massive topic. Sorry, I think the slide may have moved on. And it's clearly relevant to all health professions, and currently there are resources of varying types for medical trainees, GPs, international medical graduates, and nursing, midwifery and allied health professional colleagues. But this talk's going to focus on returning doctors, because that's more my area of expertise. And clearly Mala and Tista, the experts, are going to focus on the very much interlinked international aspect. I'm going to confine my talk to discussion arrangements in England, not the devolved nations where arrangements may be different. Next slide, please. And again, thank you. So this is going to be more of a practical overview for context, but it is an emotive issue, as I think Tista has alluded to. We're going to have a quick look at definitions and who's affected, the established resources available to help, who's missing, why does it matter, current work, and a little bit of future developments. Next slide, please. So I thought I'd start off with the definition of when you return to practice. According to the Academy of Medical Royal College guidelines, this applies after approximately 3 months out of practice. I don't think the whole slide's actually loaded there. I think there are a couple of other bits missing. That's right, thank you. But essentially, they do recommend that you use your personal and professional discretion to make sure that you are up to date, competent, and safe to return to practice. Next slide, please. This is reinforced in the work from the GMC Skill Fade in 2014, which states that there's evidence that skills decline according to a curve, with the greatest decline being in the first few months and subsequently at a much slower rate, with some consensus that 2 or 3 years out of practice should signify a need for reassessment and retraining. So you can see the definition is actually relatively vague. And of course, there is personal variation and professional judgment is required as per the General Medical Council and Academy of Medical Royal College guidelines. Next slide, please. So who's actually affected by all this? It's actually most easily divided by the currently available resources for return rather than traditional grades, because this is how support is provided. So there are established return programs for trainees and GPs. There are resources for international medical graduates. As I said, Mal and Tista are going to discuss these. And for locally employed doctors, including consultants, return is trust and departmental dependent. Next slide, please. So for trainees, there is the Supported Return to Training programme, which provides support to make return to work easier for those junior doctors who've had time out for maternity leave, research and illness. Next slide, please. It's a national scheme within England. It's interpreted regionally, but does have similar principles nationwide. It provides return to training activities and support, including pastoral, but is only for doctors on training or foundation programs. Next slide, please. There is also a Health Education England GP induction and refresher scheme for GPs who've not worked in the NHS for more than 2 years, and it's important to note that doctors from overseas can access this scheme. Next slide, please. For locally employed doctors, which of course includes consultants and their specialty doctor colleagues, return to work should follow Academy of Medical Royal College guidelines, but is dependent on terms and conditions, trust, departmental policies, human resources, and occupational health input. Now, this is not my specific area of expertise, but from personal correspondence, I think it's clear that the provision for this is variable, and it's an area that perhaps needs more research. Next slide, please. So we've had a look at GPs, trainees. We're going to discuss international medical graduates in some more detail. And we've talked about locally employed doctors. So who's left? Essentially, all those doctors who are not working as doctors, either because they're not working at all or because they're working in alternative professions. And currently there's no definite provision for this group, but it is a very topical area, and I'm going to discuss this in more detail. Next slide, please. So, does support for doctors who aren't working as doctors actually matter? Well, there are many reasons to be out of practice, and many of them can be traumatic. Examples would include mental and physical health problems, bereavements, and perhaps unfortunate experiences in the workplace. It could happen to anyone of any age. There is definite conception that doctors who are out of practice may well be older, but actually they can be of any age. And with the increasing tendency of doctors to take career breaks after foundation, for example, if a traumatic life event happens during that time when you're outside the system, you may well find that this person can't come back into practice very easily at all because they cannot access systemic resources. And I've spoken to many people who've taken planned breaks and intended to come back, but have had an event such as a bereavement, which means they can't come back into practice as they planned and have been essentially left adrift. There are certain groups who are more likely to be affected. In my outreach work, I've particularly spoken to the parents of children with special educational needs who find it very hard to work sometimes, even though they would like to very much. There's considerable overlap with the needs of international medical graduates. Of course, both groups comprise a spectrum. There is overlap, and at each end of each spectrum, there are doctors who need very little support to come back, and doctors who need a great deal. I returned to practice myself, and I'm going to discuss this in more detail in a session this afternoon about the Completing the Picture survey. But this is a quote here that I put in the supported return to training report, originally to which I contributed. So when I wanted to return to work, there seemed to be no one who knew how to help. Plenty of people wanted to assist, but there was no framework set up, no one to direct me to, and no return program. Everything had to be found out, done, and financed by me. Next slide, please. I've actually put a couple of links here to other returner accounts, and I want to draw particular attention to the one of a colleague who wanted to come back into practice. And he says here, after 7 months of trying, he realised in a fit of pique that he Googled how to be an astronaut, and he got a clear path. And as he puts it, he says if he wanted to return to medicine, he had to build his own space rocket. I don't think that suggests a great deal of support. Next slide, please. So what was happening before COVID? Essentially, this will be discussed later on this afternoon, I was working with the GMC on a 4-nation collaborative survey called Completing the Picture, discussing or looking into why doctors are not working and what might help them back. And the Health Education England was developing a return to practice programme. Next slide, please. But since COVID began in March, or began to be very significant in March, the support for doctors wishing to return to or start in the NHS is a really very fast-moving and topical area with lots of developments. I can't discuss them all here because the work on this is very much ongoing. I have been involved in many of them, but they do include the NHS England and Improvement of Bringing Back Staff initiative, obviously the GMC re-registration and re-licensing work, the recently announced NHS Reservists Bill, and work on the ongoing Health Education England Career Refresher Medicine programme. Next slide, please. As a very brief overview of Career Refresher Medicine, it is built along similar lines to the support programme. It's for all doctors returning to NHS practice, including international medical graduates, as long as they meet the eligibility criteria. We're working with GMC Welcome to UK Practice, thank you Tista, and it's launching in December. Doctors are eligible after a certain amount of time out of practice. Next slide, please. The resources are going to be allocated on a graduated system, including information, which was a real challenge for me, and I have no reason to think that has changed. There will be e-learning for refreshing, relevant courses to refresh skills, and supernumerary days for orientation. The relevant courses will include pastoral care and networking. Next slide, please. So I'd like to finish by just saying that return really does present significant challenges for both UK-trained and international medical graduates. The experience of doctors with differing backgrounds is being lost, with an effect on diversity and equality. And one of the effects of all these programs to help people back is that they in themselves, by their very existence, increase the availability of diversity. It isn't just the number of people who participate, it's the fact they exist at all, which is important in a compassionate culture. So along with support for our international colleagues, a clear, welcoming route back is at the heart of a diverse and inclusive workforce. Thank you very much. I'd now like to pass you over to Clista. I think Oliver is going to sort that out for us. Thank you.
Brilliant, thank you, Rachel. And I'd like to introduce Marla now to take stage for her part of the presentation.
Tista, thank you very much. Well, good afternoon to you, ladies and gentlemen. I'd like to begin by saying a big thank you to Tista and GMC colleagues for giving me the privilege of this opportunity to share with you my perspectives on why developing a national induction program for international medical graduates is important and what we're doing about it. Next slide, please, Oliver. Well, I think Tista has already outlined some of these points, but I'm just going to quickly recap on the why. Doctors from Black and minority ethnic backgrounds face disadvantage throughout their careers. There is a mountain of research evidence published in our journals which shows that they experience differential attainment, starting with their undergraduate medical days through to being, when they're a junior doctor, into substantive posts all the way up to the point of retirement. So there is differential attainment by ethnicity, which persists across all measures of career progression, the entire training pathway, and in all specialties. And so because of that, when I was asked to become the National Medical Advisor to NHS England's Workforce Race Equality Strategy, one of the things I did in November 2018 was to arrange a big stakeholder workshop. GMC were very much represented at that workshop, to ask them to help me construct a strategy and an action plan. And the two priorities that we set ourselves at the time was to develop a medical workforce race equality standard and indicators which would monitor, assess and monitor ethnic variation across a variety of measures of experience and opportunity and career progression for doctors in the NHS. These have been launched on the NHS England website, and the first data against those indicators is anticipated to be published before Christmas. And the other priority they suggested we must begin to tackle was to develop an induction program for international medical graduates. And that's the bit I'm going to focus on today. Next slide, please, Oliver. Oliver, next slide. Yes, thank you. Now, the thing is, international graduates cannot be expected to hit the ground running, and yet many of them are. And I'll come on to what we discovered when we asked them about their experiences. What we know is that they experience the worst levels of disadvantage, even among the Black and minority ethnic medical workforce. We know that a disproportionate number of deaths attributed to COVID-19 has been Black and minority ethnic staff. And you'll know from the evidence that has been gathered during this pandemic that 95% of doctors who tragically died belonged to a Black and minority ethnic background. Many of these were international medical graduates. And we know from the studies and the rapid appraisals of the possible explanatory drivers for why this should be, has come up with a range of factors that interplay with one another. But a key issue that has been highlighted has been how lacking in voice this group is, how they are far less likely to speak up, they haven't got the confidence, they're not heard, and to demand PPE when clearly their lives are at risk. And what we know is that at best, many international medical graduates can be treated with indifference, at worst with contempt. GMC's own commission reviews highlights how they are othered and perceived as being of lower status, and also assigned this gap filler role. And these are the issues that must cease, and the induction program will be a good place to start. Next slide, please. So what was the aim that a steering group set itself when I brought a range of stakeholders together into this kind of task and finish steering group? Our aim was to develop a comprehensive induction program for newly recruited international medical graduates, which all NHS trusts would be expected to implement. In October 2019, the Workforce Race Equality Strategy Advisory Group, which is made up of the chairs of the whole NHS family of organizations or their nominees. So this is a very senior advisory group. They approved that we should go down this path, and that's what we've been doing during this past year. And the design of the induction program is informed in two ways. We sought the views of international medical graduates in the UK. We asked them, now, what would have made your lives easier when you first arrived if this had been in place? So we asked them about their experience, observations, perceptions, and their suggestions for an induction program to be developed to ease the path of induction for future recruits, international recruits. And we also reviewed existing induction programs to identify good practice, because I'm a firm believer that if there is good practice, then we extend it across the country, and we don't put aside good practice in order to develop and duplicate that effort and produce something new. Next slide, please. So how did we set about delivering these focus group discussions with international medical graduates? We invited, by kind courtesy of the GMC, which of course has the registration details, an invitation from me, signed by me, to 1,000 international medical graduates. We decided on a methodology of purposive sampling. So we chose 1,000 IMGs with a registered address and who we knew were working in England. They were from all Health Education England regions. We included doctors from Europe and the rest of the world with less than 1 year experience, all the way to 10+ years of experience in the NHS, with or without a license to practice, and some currently unemployed. As Rachel mentioned earlier, it was important to choose this group because we wanted to know whether it was a lack of induction which had made them so lacking in integration that is what drove them away from practicing in the NHS. So we chose all of these people in our purposive sample of invitees. When the GMC colleagues proposed that they would send the invitation to 1,000 colleagues, I confess I was very alarmed at the prospect of a deluge of replies, and I was anticipating having to include hundreds of international medical graduates. I did believe that hundreds would come forward and want to tell their stories. Next slide, please. And here's what the reality was. Only 38 international medical graduates responded, and of those, only 32 attended telephone discussions, which I arranged out of clinical hours to make it possible at different times too. So there were 4 or 5 focus group discussions, some held between 6 and 7, some between 7 and 8, to make it easy for doctors who were busy clinicians to attend one or other of those sessions. Despite all of that, only 32 attended. And why was this? What was palpable, and if you ask me for one emotion that I could hear and I could sense, although these were telephone discussions, it was fear. They were fearful that their trust managers would get to know that they'd spoken to me. And you know, what were they fearful of? They were fearful of of conveying to me the simplest set of asks. They had a complete lack of information, many of them, prior to arrival. So they had no idea of what to expect when they arrived. Tista was right. Some of them didn't know how cold it was going to be in the spring when they arrived. Simple, kind, you know, humane information that you would expect any organization to offer international recruits was simply lacking. General induction was lacking in many cases. So they discovered gradually, sometimes 3-4 months after they'd arrived, that there was such a thing as an appraisal, that there was such a thing as revalidation, that they were mandatorily required to be to be involved in. There was variable levels of clinical induction that they reported. In the hospital, there was a, can you go back to the slide, please, Oliver? There was hospital induction, but very little in the way of specialty induction, which was offered. And I'll come on to explaining what I mean by that in a minute. Tista is again absolutely right. Little in the way of social and cultural integration. You know, what was good and exciting about the town that they'd been catapulted into to live and work in? What was its history? Where were the tourist sites? Where could they go over a weekend? Language and communication barriers were a problem. IT was bewildering because some of them had never seen computers in the hospitals that they'd worked in their countries of origin. And the need, there was a need, highlighted in these focus group discussions for mentoring and support. Next slide, please. So, and what were our findings from a rapid review of existing induction programs? Exactly as Tista said, that the Welcome to UK practice was an excellent introduction, and it surprised me that it hasn't been made mandatory in all these years. Only about 60% or thereabouts, as I understand it, actually get to take even that half-day induction. There was lots of reasonably good clinical induction for formally recruited groups of trainees, such as those who arrive on the MTI program. There was hardly any induction for hospital salaried doctors or individual consultant recruits to trust. The majority lacked structured social support. As I mentioned, the language, communication, and IT were very inadequate. There were no good examples of those. And there were some great examples of social integration delivered always, it appeared, by senior international medical graduates who had recognized that there was some need for kindness and would befriend newly recruited IMGs, ask them if they knew where the supermarkets were, or whether they knew where to recruit, where to enroll their children to school, and so on and so forth. And it intrigues me that white colleagues have not contributed to the social integration. Next slide, please. So what are we developing? The Welcome to UK practice is excellent. So we've decided we're keeping it and making that a mandatory part of the national induction. Modules are being developed for IT, pastoral care, hospital induction, clinical induction, and so on. The health education in England has been superb. In London, there is a fabulous language and communication unit, which is looking to how it can develop a replicable module which can be applied and administered and delivered to all international recruits around the country. In specialty-specific induction, the beacons have been the Royal College of Psychiatrists and the anaesthetists. The psychiatrists have prepared a short, brief introduction to what are the 3 things, what are the 4 things that you must know about the way we practice mental health if you come to practice in mental health in this country. So it could be about the Mental Health Act or some other aspect of mental health practice. But that's the sort of thing we're expecting all colleges to do as we go along. Next slide, please. we are at a stage where these modules are almost ready. A pilot could begin soon. Several trusts have volunteered to pilot the induction program. We intend to embed a rapid appraisal into the program pilot, because the intention is not to do an in-depth 3-year academic evaluation, because we need this induction program now. And the intention is to refine and tweak the induction program as we keep going with the pilot, and shape it to the pilot findings in real time. We plan to work with Health Education England to create a web-based program, so it's there on the web for all HR departments, educational supervisors, and indeed the IMGs to take a look at, and to see if everything on that checklist has been applied to them and they have had that all of the modules delivered to them. And we are very hopeful of a rollout to the NHS in April 2021. Key challenges remain that we need to agree a host organisation formally, because of course Health Education England is responsible for the education of trainees and junior doctors, but not for doctors in substantive posts in hospitals. But Health Education England has very kindly taken on and are reviewing whether they couldn't host forevermore the induction program, which of course will require updating in due course, some accountability, ensuring that it is embedded as part of the whole learning journey of doctors in the system. And of course, we will need some substantial and substantive sources of funding. But my justification is, even a half-decent firm in the country would set aside a tiny amount of time and resource to induct new recruits to their factory or their workplaces. And I think this is the least we could do for a group of people who are coming to serve this country and its NHS from overseas, and who are actually working with our most vulnerable sections of society. So, this is about setting them up through integrating them with life in the UK and life in the NHS in such a way that they are enabled to achieve their best. So that's the hope. And I hope that everybody who's listening and everybody around the country will support us in this journey and make this a reality. So thank you, Tista. I hand back to you.
Thank you so much, Marla. Thank you. Yes, so thank you both, Marla and Rachel. I think you have both very eloquently made the case that we need to act, that we need to do something. So what we'd like to do now is breakout rooms for about 10 minutes or so before we return to plenary. And breakout rooms, what we will do is really explore. We've made the case, so we'd really like to hear your thoughts on how we actually get this to happen. How do we make it happen? So questions will be broadcast into the room, but first, just by way of brief instruction, because those of you who, like me, might be used to Zoom, where we can automatically get put into breakout rooms, the way it will work here, the names will appear on screen. There will be rooms by colour, so the purple room, pink room, etc. Pick any colour. You don't need to allow 15 seconds for facilitators to join, because the marvellous Oliver has set it up, so we don't need to worry about that. So just click on any room. All questions the same in each room. Once a room is full, but it'll be greyed out, so then click on the next one, but there is room for everyone. So with that said, can we launch the breakout rooms, please? And I will see some of you in there in a moment. Thank you.
everyone, can you hear me?
Yeah.
Yeah.
All right.
I think we have everyone back now. So that was a conversation that we could have had for much longer, and apologies to my colleague who was just sharing some insights there in our breakout group. But certainly we had some really useful suggestions shared, which I will share with you as we wrap up. But before we do that, in case there are any questions and answers we want to put to the panel, let's use the last few minutes to see if there's any Q&A, and Rachel, Marla and I will then share our thoughts from the breakout rooms. I'll just go into question and answers. Okay. Right, so I can see that there is a question from Andrea asking about champions in the trust to liaise about doctors returning to practice, or for the IMG. So that is something that can be explored. Now, Marla, if I may come to you first on the champion question. As far as I know, there are a number of places that do have international tutors, and there's a couple of trusts where I've worked very closely where the international tutors have done a great deal. Do you know a little bit more about that? Can you say something about that?
Oh, thank you. On the issue of champions, we haven't used that word in the module, but it makes it very clear that there are 2 or 3 things that need to happen. You know, the recruit, and I think this could work for returners to practice as well. They need the overall educational supervisor for the trust needs to allocate a mentor, an educational supervisor, and a buddy. And now, through the workforce race equality strategy, most trusts have got a Black and minority ethnic network, and Black and minority ethnic champions who understand that aspect of variation and difference and how to address it. So we're asking them to you know, be there and understand the needs and observe what's happening. But for formal roles to be allocated to somebody who offers to be a buddy, somebody who says, I will be a mentor, and who's trained in being a mentor, but the educational supervisor being having a formal accountability to ensuring that the person is properly inducted into the system. So 3, it's not layers, but rather 3 kinds of supervision, support, and ongoing you know, facilitation is what we're asking to happen in each trust.
Fabulous. Thank you, Marla. And Rachel, has there been any discussion about champions for returners or a similar type of role?
Well, there's been, as Marla alludes to, there has been discussion about mentors, but the challenge to an extent, whilst it's still being explored, is making sure those mentors in themselves have the correct processes to refer to if there are issues they feel they need to support network in themselves, as all mentors do. Yeah. Now, as I've said, whilst it is separate, Care for Me is related to the support programme. And the support programme does have champions in trusts. So actually, the purpose of these breakout rooms was to bring ideas to us. And that actually is an idea I will take forward, considering whether we can also take this idea forward for Care for Me. So yes, thank you.
Brilliant. No, thank you, Rachel. And yes, I think that brings us neatly with just a couple of minutes left to reflect on ideas from the breakout rooms. And I think that's a really, really positive one. And one that came up from mine, and Marla, I'll come to you in a moment if anything particular came from yours, but one that came from mine that I think was really interesting was around how we make it happen, and that might be including objectives and PDPs, etc. So that can be a powerful one, can't it? And it just keeps it in the forefront of colleagues' minds. So, but Marla, any reflections on yours as we wrap up?
Well, I have to say that we got chatting about what the issues were, never got around to actually coming up with an action
Fair
plan.
enough.
But I think what there was an quite an overwhelming recognition, if you will, and support, because there were colleagues in our breakout session who had similarly traveled around the world before coming to Britain. Some of our colleagues were not, had come from other countries of origin, as in Stephanie's case from New Zealand. So and who understood how bewildering and intimidating it can be to not only have to hit the ground running as clinicians responsible for patients sometimes on day 2 or day 3 after arrival, but also be just getting used to this new environment that they're living in. And I think we were naturally drifting to that position, that the cultural and social integration and just making them comfortable in their environment, and not to laugh at people or be indifferent to the kind of questions they might ask is so different. To make them feel welcome, valued, and to function well. I think we were.
Yes, I think that neatly harks back to what Victor Adebowale was saying earlier about it's about the questions that we ask as leaders rather than the lead guitar heroic leadership. So on that note then, thank you all. I really enjoyed the conversations we had. It would have been lovely to have longer. There will be a note of your conversations because, as I said at the start, we don't want this to be a workshop and then done. This is ongoing, and it's not an ongoing conversation merely. It's an ongoing call to action, because we've been having this discussion for, well, unfortunately, a good couple of decades. So we need to act, and it's great to see that there is such ongoing good work in train, and your thoughts will inform what we do next as well. So thank you very much. Look forward to seeing you, albeit virtually, throughout the rest of the conference. Thank you. Bye.
Thank you.
Thank you.
Are you still there, Tista?